That brings me quickly to the end of the clinical update. I will go straight into the epidemiologic update with the slides. The epidemiologic update for December 13th is as follows. Next slide. Looking first at the epidemic curve, which shows the samples by the date of collection, we can see, next slide, that we've had the rolling average continue to come down over the period. Please continue to the next slide. We've had that rolling average continue to come down over the period late November into early December. We're going to need to move that band at the bottom so we can see that properly. And if we are able to, there we are. If we're able to see the graph, we can see the different colors representing the different months from July through to December. We see two peaks in November that correspond actually to the number of individuals that were within the prison system that tested positive at that point in time. And once that incident had been contained, we returned to what were our baseline sort of levels, which is what we're seeing coming towards the end of the graph in that dark gold color. And we see that the black line representing the rolling average has now dropped back to its sort of previous trajectory, moving slowly downwards as we move towards the end of the year. Next slide, please. The demographic characteristics have remained fairly constant. Next slide. Looking at the age and sex distribution of the cases, we can see that there are about 54% of the cases that are male, and that 54% is a slight increase over the 52% we'd been reporting previously, and that's really driven by the number of cases in that prison cluster, which is a male population. The 25 to 49 age group still contains the majority of the cases at 55% of the total, and the under 25s fall at around 17.5%. Next slide. We do see, however, that among the fatalities, there is that 3-to-1 ratio of males to females. We have seen the majority of the fatalities above the age 60 age group, but there have been fatalities even in the younger age groups, and the majority of the individuals who have passed on have been persons who have had some sort of pre-existing chronic condition, whether it is neoplastic or immunological or chronic disease metabolic. Those are the sort of conditions that have been associated with increased risk of adverse outcomes. Next slide, please. Looking at the geographic distribution, we want to point out that while this map shows the communities with the most activity, the numbers need to actually be looked at within the context of the legend, that is the little series of colored bars off to the right of the map, so that the highest numbers are represented by the darkest red color. But at this point in time, over the last 2 weeks, epidemiologic weeks 49 and 50, there have been generally smaller numbers across all the communities, so that the highest number in this range, of this legend, is actually 4 individuals in a given community. Those are then summed up to the number of cases per county, and those counties are outlined by the darker black outlines. We have 9 counties, and what we are seeing at present is that the counties with the highest rates of disease, the highest rates of COVID cases, are actually now Tobago, St. Patrick, and St. George East. Now, this actually is a change from the original set of counties that we would have listed earlier, which was St. George Central, Caroni, and Victoria. Those have been displaced downwards by Tobago, St. George East, and St. Patrick in terms of numbers of cases per unit population. So that's what we mean when we talk about rate. So Tobago has an increasing number of cases that's high relative to its overall population, and the next in line is St. George Central and then St. Patrick. And these are the areas that we'd like to give some additional attention to, those public health regulations, to the adherence to the advice not to gather, to adhere to the hygiene and the physical distancing, adhere to the avoidance of work and gatherings when you're ill, because we are trying to drive the rates down in all communities where we see increases, we want to reinforce that message. So that brings me quickly to the end of the epidemiologic update. I'll turn you back over to Mr. Alexander.
Thank you, Dr. Hines. I now invite Dr. Sappho Fraser to update you on the work being done in St. George East County to combat COVID-19. Dr. Fraser.
Thank you very much, Mr. Alexander, and good morning to my colleagues, Dr. Hines and Ms. Hollingsworth, and to the listening and viewing public of Trinidad and Tobago. This morning, I do want to take some time to talk through some of the epidemiology of the what's going on in St. George East, and I just have a few slides to show you to help to bring a visual of what's really going on. So if we can start by showing the first slide. The next slide actually gives you an idea of how wide and extensive St. George East is. It is bordered on the west by St. Joseph, and then it goes as far east up to Valencia, and then it extends north to Blanchisseuse and south to Caroni. So it's a very extensive county. It is also a very well-populated county, so it has over 200,000 persons living there, and this is the census from 2010-2011, and you can see it's a very, very densely populated county, and it's a very extensive county. And I know Dr. Hines would have mentioned a little earlier on that this county is one of the counties where the rates are a little up than some of the others. In the next slide, this just gives you an idea of the distribution of the cases that are in St. George East. And St. George East is outlined by the purple color, but all those purple dots would represent cases. And as you can see, the cases are strung along the east-west corridor all the way from St. Joseph up to like about Arima. Lots of dense cases. These of course would represent all the cases we've had since we started the infection. But it gives you an idea of where the cases are located, and it also gives you an idea of the communities that are most affected by COVID-19. In particular, we are noticing areas such as Arima proper, La Hoquita, Aruca, Curep, Tunapuna. Those tends to be our hotspots, our areas with a larger number of cases. And I will just want to, at this point, re-emphasize the point Dr. Hines made about the need for continuing to observe all of the public health regulations, all of the social distancing, the mask wearing, the hand sanitizing. Those things are very, very critical and key, especially if you are trying to stave off recurrent infection. One of the things we notice a lot is that a lot of infections are taking place when people gather in their own homes with extended family members and extended friends, and especially now as we are approaching the Christmas season, I do want to say let's make a very big effort to try and to decrease the amount of gathering in closed spaces so that these numbers don't continue to go up. The next slide shows just the current situation of all the cases we have right now, just the comorbidities, which is which of our patients have what other conditions apart from COVID-19. And as you can see, hypertension and diabetes are the two conditions that are affecting our clients the most. Next slide. And also we can see, this one just shows how many of our patients do have comorbidities and how many do not. And most of our patients that we get do not have comorbidities, just about over half, and just under half would have some of those comorbidities that we just saw in the previous slide. All right, let's go to the next slide. This slide shows the number of persons or the percentage of persons who are symptomatic, and symptomatic would be those persons when they got infected, they became infected, and symptoms were the thing that alerted them to the fact they had an infection. We have a small percentage of people, about 11% of those currently who are currently with infection, who never showed any symptoms at all. They were asymptomatic, and most of those may or may not have been in contact with someone who was also positive. We also have some of those, a large percentage of those persons who have resolved, so they had symptoms, but the symptoms have resolved. And so altogether, the current group of patients who are stable without any symptoms is much larger than the existing symptomatic group. Next slide. This slide just shows the male-female ratio of the current cases, and this is patterned in the national picture. There are a bit more males than females, it will seem here. Next slide. And this one shows the age distribution. And the two taller peaks would be the distribution of ages of clients who have COVID-19. And they show that the two taller peaks are between the ages of 20 to 59. And that's what we've been seeing across the board, that the population, the younger population is the population that is most affected in terms of numbers of persons to get COVID-19. And so that is what we're seeing in St. George East as well. We have a smaller number, about 2% of persons over 80, and a smaller number as well of those between 0 to 19. But the majority of persons between the ages of 20 and 59, that's the big bulk of those getting infection in the county of St. George East. That actually brings me to that was the last slide. And it's just to give you an idea of what is taking place within the context of St. George East, and to highlight those areas that would be considered by us to be kind of hotspots and need to make sure that we're paying a lot of attention to the public health message. So let me hand back over to Mr. Alexander.
Thank you very much, Dr. Fraser. I now invite Ms. Lyra Thompson Hollingsworth to provide some caution on the consumption of alcohol, especially during this Christmas and COVID-19 period.
Thank you, Mr. Alexander. Dr. Hines, Dr. Fraser, media practitioners, and members of the viewing and listening public, good morning and season's greetings to all. The National Alcohol and Drug Abuse Prevention Program acknowledges that festive seasons such as Christmas are often punctuated by increased consumption of alcoholic beverages, and it is therefore suitable at this time to remind the public of a few key points as it relates to challenges associated with COVID-19, and we will now switch to the presentation. Next slide, please. Next slide, please. This year, households have been asked to minimize external interactions, and it is anticipated that there will be no events such as large family gatherings, staff parties, parang festivals, and other such events. Additionally, there is currently no in-house service of alcohol at bars and restaurants. It is therefore understood that levels of alcohol consumption at this time will be greatly determined by household purchases. The public is asked to conduct this activity mindfully so as to avoid the occasion of heavy episodic drinking or binge drinking while at home, particularly if there are minors in the home. Next slide, please. Heavy consumption of alcohol places the individual at risk for developing or exacerbating non-communicable diseases such as diabetes and hypertension, both of which are underlying health conditions which lead to complications for persons who contract the COVID-19 virus. Next slide, please. Alcohol use, especially heavy use, weakens the immune system and reduces its ability to cope with infectious diseases, including COVID-19. Heavy alcohol use is a risk factor for acute respiratory distress syndrome, one of the most severe complications of COVID-19. Next slide, please. Alcohol also alters your thoughts, judgment, decision-making, and behavior. Individuals are urged to avoid intoxication so that they can easily observe protocols such as mask wearing, social distancing, and hand washing or sanitizing. Next, please. Alcohol consumption may intensify fear, anxiety, or depression, especially when people are in isolation, and should not be used as a coping strategy to deal with stress. Next, please. Never mix alcohol with medications, even herbal or over-the-counter remedies, as this could make them less effective, or it might increase their potency to a level where it's toxic and dangerous. Also, do Do not consume alcohol if you take any medication acting on the central nervous system, such as painkillers, sleeping tablets, antidepressants, etc., as alcohol may interfere with your liver function and cause liver failure or other serious problems. Next, please. If you are a non-drinker, there are no health reasons which should persuade you to start. However, if you are an adult who consumes alcohol, the following tips are offered. Avoid alcoholic beverages when thirsty. Your thirst may cause you to consume the drink much faster than you should. Space out your drinks. It takes the body approximately 2 hours on average to metabolize one standard alcoholic drink. Stay hydrated. Having water or other healthy non-alcoholic beverage options between drinks helps to manage intoxication and also prevents hangovers. Have a meal. Having a drink on a full stomach also delays intoxication. Do not consume alcohol in the presence of minors. And finally, avoid mixing alcohol consumption with the use of other drugs or with the consumption of other intoxicating foods such as cannabis edibles. Next slide, please. If you or a loved one may be experiencing alcohol dependence or problem drinking, you are urged to call 877-WELL, that is 877-9355, or you may email us at NADAPprograms, that is NADAPPP programs at health.gov.tt for further information. Thank you for your attention. I now hand you over back to Mr. Alexander.
Thank you, Ms. Thompson-Hollingsworth. We now move to the question and answer segment. We once again remind our media representatives to state your name and the name of the media house that you represent before asking no more than 2 brief questions. Please ask your questions one right after the other to the relevant members of the panel. If time permits, we will accommodate a second round of questions, this time 1 question per media house. Today we begin the question and answer with questions from 98.1.
And very good morning to you, Mr. Alexander, and members of the panel. Stephen Cummings here, 98.1 FM. My 2 questions are really for Dr. Hines. Dr. Hines, I heard, I want to sort of revisit this issue of herd immunity. And I think, as we go forward in these mitigation, strategies and so, sometimes we forget. I heard that there is a formula to calculate herd immunity based on incubation period or cycle in which there are suspected COVID-19 cases, meaning that if you have, let's say, a greater percentage, say 60% of the population perhaps being vaccinated, you could achieve a fair level of population protection. Is herd immunity one of the ministry's ultimate objectives? And the second question, Dr. Hines, the WHO, I understand, does not approve vaccines. It is agencies such as the FDA and in the US and the EMA, meaning the European Medical Agency. What the WHO does is that it takes approved vaccines, I understand, and ensures that there's equitable, there are guidelines and equitable distribution. My question is, once and if a vaccine is approved for Trinidad and Tobago, where is that approval going to be sought from, or who is going to, authorize that approval? Thank you.
Okay, thank you for the questions, Mr. Cummings. Firstly, with regard to herd immunity, the calculation for herd immunity is basically not based on the incubation period, but rather on what we refer to as that basic reproductive number, that R0. So if one individual will infect 2 to 3 other individuals within the course of the infectivity, that R0, that R0 number is between 2 and 3. The fraction of the population that needs to be immune in order to generate herd immunity would then be 1 minus the inverse of R0. So that for something with R0 between 2 and 3, as we currently have for COVID-19, you're looking at between 60 and 70% of the population that should be immune in order to then halt that ongoing transmission or reduce the risk of ongoing transmission, because the virus literally can't find a reasonable number of susceptible hosts to jump to. So with the strategies that we have outlined previously with respect to the vaccination and the acquisition of vaccines, what we have stated is that the first tranche, that first set of vaccines that we will be receiving, is targeting 20% of the population and focusing on those vulnerable individuals within the population, those with comorbid conditions, those in the older age groups, etc., as well as those who are what we consider frontline staff in various disciplines and therefore at higher risk. As we acquire additional quantities of vaccine, then the overall population coverage will be increased, with the objective eventually of getting as much of the population covered as possible and therefore approaching the state that we refer to as herd immunity. The first phase will not get us there, but the next sets of vaccines that become available and that are distributed should get us closer to that objective. Now, the international agencies don't approve anything for any one sovereign country. So the approvals will only really be looked at within the context of the considerations within the Trinidad and Tobago's government and Ministry of Health of the existing evidence. So what we do is not that we're seeking the approval, but we're looking at the evidence that a vaccine is safe, that it has been tested, that it has gone through the appropriate trials and the appropriate length of time to look for the potential longer term side effects, things like that. And then we look at the consensus of various agencies that would have also examined the data and looked at the same things and come to a conclusion on whether these can be used or not. So the WHO does something quite similar. It looks at the evidence, it looks at the outcomes from vaccine rollout, and then it says, yes, this is considered by our standards to be something that is safe for population use, and we are in constant contact with the WHO via our Pan-American Health Organization / World Health Organization representatives within Trinidad and Tobago. So we will remain in contact with them as they and we review the outcomes of the vaccinations, and that will determine in the final instance which vaccines will be chosen. So I hope that clarifies the process and answers the question.
Thank you very much, Dr. Hines. We now go to Wired 868.
Good morning, everyone. Fayola Bostic from Wired 868. My two questions, I believe, will go to Dr. Hines as well. My first question is, how do we classify deaths due to COVID-19, especially when there are comorbidities? So how do we know that somebody died of COVID-19 as opposed to some other ailment that they had? And my second question is, do we have any idea of why men are so disproportionately affected in terms of deaths by COVID-19, and if we saw anything similar with other coronavirus diseases like swine flu or anything else?
Okay, thank you for the questions. The first, well, let's go with the second question first. The distribution of coronaviruses and the adverse outcomes among men as opposed to women, this has actually to some extent been demonstrated with the Middle East respiratory syndrome, MERS coronavirus, where we did see more men being affected and more men dying, although there isn't a solid piece of evidence that suggests why that is. Certain differences in physiology, certain differences with respect to distribution of receptors in accordance with hormone levels, things like that are all theories that are being thrown around, but we really can't say off the bat with the evidence that we have right now what is the real driver behind the male preponderance of the deaths. So we can't really give a definitive on that, but we do want to continue to warn both males and females to seek care if any sort of severe or extreme symptoms are being experienced. So we don't want to wait around to become increasingly breathless and then collapse at home before calling an ambulance. Once we're starting to have increasing symptoms of discomfort, then what we do want is early access to medical care so the best possible outcomes can be had by all persons. So hopefully that takes care of the second question. Can you clarify that first question for me? Can you just repeat the first question with a little more clarity?
We hear that people die from COVID, right? So I'm just asking, how do doctors classify a death from COVID, especially when they have comorbidity? So how do we know that a person didn't die of their underlying medical issues as opposed to die from COVID?
Okay, all right, that is a little clearer, thank you. Now, what happens is that sometimes something like COVID-19, which puts an immense strain on the body's physiology in general and on the immune system, can make other pre-existing conditions worse. It can make pre-existing problems take a greater toll on your body, on your physiology, and cause decompensation and death, and vice versa. The existence of pre-existing conditions also weakens your response to the new virus. So the two things can work, what we call in tandem. They work together. So if someone is diagnosed with COVID-19 and has pre-existing conditions, and those pre-existing conditions worsen and result in their demise, then that's still counted as a COVID-19 death, because it is taken as a given that the deterioration in their conditions was actually driven by this new virus that has come in and made things harder for the body to cope with. So we generally look at the way that the person would have progressed between when they got ill and when they passed on, and once it's in keeping with that sort of trajectory, that sort of pathway, it's considered a COVID-19 death, even with the pre-existing conditions. It's an excellent question.
Thank you, Dr. Hines. We now go to AZP News.
Hi, good morning. Priya Bihari, azpnews.com. Good morning to everyone. My first question has to do with the map that Dr. Hines showed and the area in south of Trinidad that had the dark, the larger concentration of COVID-19 cases. Can you tell us what area is that, and what has caused that spread? Has the contact tracing been done? And arising out of that, my second question has to do in terms of the policy of the ministry. Does the ministry take into account, certain cultural differences in different parts of the country when you make, put out your policy in terms of COVID-19 prevention, in terms of maybe urban, rural areas, etc., like that? Thank you very much.
Okay, again, I'll go with the second question first, because what we have been actually doing is using the information that we have, the geographic information in particular, to target the various locations, various communities where there has been seen to be increased or increasing numbers of cases. And when we do this targeting, we do so utilizing communication methods and mechanisms that are appropriate to the setting, whether it is urban or rural. In fact, I may even invite Dr. Fraser to give a little more detail on how that sort of targeted communication may play itself out using his county as an example. Dr. Fraser?
Yeah, one of the things that happens when we identify an area that is a hotspot, along with the corporate communications department, one of the things we do, for example, is that we go into that area with public messaging. And we have recently started using a number of ads on the radio, in some of the supermarkets, driving through the areas with public messaging about coronavirus, about the public health measures, so that we could identify or certainly bring to the fore in those identified areas that there is a uptick in your area, and two, remind them of the message, so the message is inundated into the particular community. So that's one of the things we do when we identify hotspot areas. Obviously, one of the other things that is helpful as well is in those areas, the health centers, the messaging in the health center also is increased, and people who come into the health center, they are also inundated with the need for making sure you are following all of the COVID public health measures that we have outlined. So it's a lot about health education and targeted health education for those particular areas.
Okay, now with respect to the first question that you asked, the area that we saw with the largest number of cases in that southern county being the county of St. Patrick, was in fact the Penal area. But what we're going to find is that the places that have more people are obviously going to have more cases. So yes, the contact tracing was done as it always is, and beyond the contact tracing, what's more important at this point is the continuing enhancement of public education that the virus is still in the population, and once there are people moving around and the potential for individuals with the virus to go into more populated areas, we're going to continue to need to remain on our guard. So the contact tracing takes care of our checking where the potential for spread from known cases was, or where the potential may be. But more important than that, the thing that reduces the risk of spread from unknown cases is that enhanced social distancing or physical distancing, hygiene, adherence to the guidelines that will reduce the risk of transmission where illness is not known. So thank you again for the question.
Thanks again, Prior. We now go to TTT.
Yes, hi, good morning. Good morning, guys. Sonolala, TTT News. I just want to update on the multisystem inflammatory syndrome in children, the MISC. Has there been any increase within the past week or so?
Okay, I'm guessing there's only one question in that case. There haven't been any additional new cases reported to us yet, but we will remain in contact with the pediatric specialists so that if we do see a continuing increase in those presentations, we will be sure to advise the public accordingly.
Okay, and we have a follow-up question from 98.1. Okay, so in that event, what we'll do, we'll take a question from I-95, and the question is to Dr. Hines. Can you speak specifically to the epidemiology of the disease specific to Tobago? The cases in Tobago, are they imported primarily from sea travel, air travel, or is it evenly distributed across both forms of travel?
Okay, thank you for that question. While I don't have the information on which mode of travel the persons who may have come across from Trinidad to Tobago would have utilized, the epidemiology of the virus in the population at this point in time is not solely based on who traveled, but also based on who was ill within the population and then got into contact with other individuals. So while yes, there would have been introduction because of travel between the two islands, the ongoing transmission within family settings, workplace settings, etc., is the factor that we really need to focus on if we want to reduce the continued spread. So the epidemiology goes from introduction to onward transmission, and whether it is by sea or by air, I am unable to say at this point in time, but the means of transport isn't so much the issue as the introduction into the population and what happens thereafter. So again, we want to advise that individuals who know that they're not feeling particularly well, who've begun to develop respiratory symptoms, if they know they've booked travel, you can either cancel or rearrange. You don't want to travel while you're ill. If you start to feel ill after you have traveled and you've already gotten to your destination, then you can notify the health system in such a way that we can reduce the risk of transmission. These are the things we want to focus on to reduce that ongoing or that continuing risk of transmission within the population. Also, if you know that you've interacted with someone who seemed to be under the weather, seemed to be having any sort of respiratory symptoms, and then you yourself begin to feel symptoms, it's a good idea to go get a test done, verify what's going on with you so that you don't present a continued risk of spread to your family members, to the members of your workplace, etc. This is what we really want to focus on with respect to the epidemiology of transmission in any setting, and Tobago is no exception. And we have a good team working with the public health system there, and the cooperation with that team in answering the questions on potential exposures, movements, where you would have been prior to being ill, where you may have gone after being ill. Giving honest answers, complete answers to those questions is going to help to bring that transmission under control.
Thank you very much. Newsday, we are now ready for your 2 questions.
Good morning, Narissa Fraser from the Newsday. Touching back on Miss C a bit, are we seeing it presenting itself in a particular gender more than the other? Is it more common in males and females, vice versa? And secondly, are we seeing any cases of Miss A in adults locally as yet?
Okay, the gender breakdown of the Miss C cases would be better actually addressed by the pediatric specialists who have the full breakdown of all the cases that they would have seen to date. So I don't want to misspeak just based on the last couple that we would have been aware of. With respect to Miss A, I do not believe that we've seen any sort of presentation along those lines in adults. What we would have seen is the increasing difficulty in breathing, the adult respiratory distress syndrome, things like that, that we expect if you have a severe respiratory illness affecting an adult. So in the absence of information to the contrary, I would have to say no, we have not seen any in the adult population. But when we have the actual specialists on, I believe they'll be on Wednesday, may be able to address that in a little more detail.
Okay, thank you, Dr. Hines. We will try our best to bring on that specialist as soon as possible. It seems that questions surrounding Miss C quite popular. For now, we would return to 98.1 for your follow-up question. Mr. Cummings?
Yes, thank you again, Mr. Alexander. Just one final quick question. Dr. Hines, maybe you can address this as well. Are persons with a history of multiple vaccinations at any greater risk to overall health with a COVID-19 vaccine if it becomes available? Thank you.
Okay, I'm a little unclear on what you mean by history of multiple vaccinations. Most of our population would have had multiple vaccinations. Our vaccination schedule involves multiple vaccinations. So I'm not entirely clear on the question, but in general, having previously been vaccinated for any of the existing things that we vaccinate people for does not present an increased risk of any adverse outcomes for vaccination with the new COVID vaccine. That hasn't been shown in any of the shorter or longer term data analysis coming out of the vaccine trials. So the short answer, no. Previous vaccination history does not increase your risk of adverse outcomes with this particular new vaccine.
Thank you very much. We now go to Wired 868.
Hi, just one last question. This is concerning the protocols for travel. I'm wondering, we have seen that other islands up the chain have been open, have been receiving tourists and things like that. And I'm just wondering if we've been looking at what are, if anything, are they doing differently that allows their borders to be open that we could try here?
Okay, now the situations in other islands up the chain are actually quite different for a number of reasons. So a lot of the smaller islands have had no cases or very few cases over a prolonged period of time, and they are actually also weighing the sort of risk versus benefit, the cost versus benefit, because their economies are largely driven by those tourist arrivals. So while they may be knowingly putting themselves at some measure of risk, and you have seen where tourists have come in, have been ill, have introduced the virus into a native population in one of the islands, and there has been an outbreak response that needed to be generated as a result of that. They're still weighing that against whatever drives their economic engines. And the volumes of travel that would be considered would again be determined by those sorts of considerations from one island to the next. What we are currently doing is we're attempting to preserve the status, so to speak, of the population with its relatively low and hopefully decreasing numbers of cases at this point in time. So this is not a point in time at which we'll be looking to increase the risk to the population by having increased influxes of individuals, especially as the situation globally is one where the source countries, the places that people are most likely to be coming from, are in a state of increase. Their cases are going up, so the risk in their populations is currently higher. So that's sort of, those are the epidemiologic considerations that are currently in play with respect to our considerations on international travel at this point in time. As we always emphasize, though, all decisions with respect to borders and with respect to travel will be taken at the level of the Prime Minister, and that information, if and when it is to change, that information will be announced from the level of the Prime Minister come down.
Thank you, Dr. Hines. I know that with the Christmas season coming around and which we are in, there have been a lot of family gatherings, and we have been running a short CNN clip that speaks to the dangers of family gatherings. So at this time, please sit back and pay attention to the clip that we have to run.
I know that there are so many people that are going through dark times right now.